What you've asked me to do today is explain how developmental pediatrics folds into primary care. I think the first thing I would need to know would be what a developmental pediatrician is, what we do, and things like that. So that's where I decided to focus. My background is that I actually started working with kids with disabilities after a miserable summer working with kids who were very wealthy and didn't have disabilities. It was a camp where in upstate New York, about 150 kids. We had 3 campers per 1 counselor, and they all had disabilities of one sort or another. Very few medications used, a lot of hands-on redirection. And then I went to college, continued to work there in the summers, went to medical school, continued to work there in the summers till I could not any longer. And lo and behold, ended up in pediatrics. I did physiatry, which is working with kids in wheelchairs and disabilities for a bit, and then ended up in general pediatrics for about 10 years. Eventually, I noticed, as did most of my peers, that a huge portion of my practice was kids with developmental differences and backgrounds who had just different behavioral issues, and ended up subspecializing in developmental pediatrics. So I come about it honestly, and thinking about it, I guess one of the things prepping for this lecture that I thought about was what's different in general pediatrics versus developmental, because I've done both. And I think the biggest difference is I have the privilege of having 45 minutes to 90 minutes per child and family versus 15 to 20. The other difference is that when I'm doing in developmental is very similar to what I did in primary care, except with a different spin to it. So in primary care, I might ask about diet, elimination, and sleep. And in developmental, I'm going to do the same thing. So when someone gets a report from us, it's going to look very, very similar to an intense general peds evaluation. But what I'm looking for is quite different. I assume somebody's looked at nutrition and sleep patterns and all the routine things. And I keep my ear open for those, but it rarely comes up as an issue. Everybody's got those down. But when I take a dietary history, and you've heard me ask this, I'll ask things like, I might have an 11-year-old patient and I'll say, did they eat stage 3 foods as a baby? And the parents look at me oddly because I'm taking a baby food history. But what I'm really looking for is the oral mechanics of it. When we eat complex foods like stage 3 baby foods, stews, things like that, it takes a lot of organization. It takes a lot of neurologic organization. It takes a lot of muscle control because you have to pocket the pieces and swallow the liquid. So when I take a dietary history, I'm looking for that. Or I'm looking for something like in a kid with autism. They might be not only specific about what foods they want, but they actually are sometimes even brand specific. And that's really important because if a child can only conceive of a chicken nugget being a Swanson's chicken nugget, that's a really different thing from a child who is, quote, picky and likes chicken nuggets, and we can buy them from anywhere. I've had literally multiple families who go to Burger King and buy as many nuggets as they can because their child will only eat that brand of nuggets. So as I'm taking that history, that's really the nuance that I'm looking for. Elimination patterns are very similar. Everybody deals with constipation in primary care. I'm looking at the issue of, is the child not toilet training because they are cognitively not there yet? So let's say they're 9 years old and they have a cognitive adaptive impairment. So functionally then they might be 3. Is that a 3-year-old who's aware or not? And then I can ask further questions to decipher, is it an issue of encopresis, or which is just the inability to control the bowels, or is it that they're cognitively not ready yet? Very different issues. And as anybody who's tried to toilet train a child before they are developmentally ready, it is likely to meet with little success. So I'd like to differentiate between those two. Sleep patterns come up a lot. So I really talk a lot about the general pediatric things, but with a different spin. Sleep patterns, as everybody can imagine, can be something as straightforward as a parent falling asleep with the child. So you get that habitual night wakening that we all talk about and train. But it also could be something like, I had a child just 2 weeks ago who awoke at the night at the exact same time every day, exactly the same time, seemed disoriented, was very agitated, very different than he is during the day, and it was predictable. That worries me a lot for seizure activity, and because it's just an unusual pattern. Early mornings are a time that's common. Again, I'm listening to that developmental history in the context of what medical issue might be underlying it, what behavioral issue might be underlying it. And in that case, I don't know if he has seizures or not. That's for neurology to figure out. So then I'm going to check with the primary care provider and refer them further. I won't be comfortable addressing that child's sleep patterns as a behavioral issue until I rule out the medical part of it, and then we'll deal with it from there. It's really interesting because there's certain patterns that fall to certain types of illnesses. For instance, you and I work a lot with kids with cerebral palsy. There's very distinctive patterns of sleep disruption with muscle pain versus sleep disruption because the parent is co-sleeping with them and then goes to their own bed. And that's what we're looking for. The types of patients I see, I don't get any regular 6-month-olds anymore who light up the room. But I do get to work with kids with genetic disorders. So I have a lot of patients with Cornelia de Lange syndrome and Down syndrome, Noonan syndrome, that kind of thing. I get to work with a lot of kids with medical issues. So if somebody has epilepsy or they've had radiation because of a certain type of tumor, I'm very interested in seeing those kids. I'm also very interested in seeing other kids with chronic medical illnesses. If it's serious enough that it's impairing daily function, it has the potential to change family dynamics, parenting, and education. And I want to work with the concepts of resiliency and things like that to decrease that impact. There's a lot of research that's been done since the 1950s on resiliency. So basically the concept that somebody can function to a better outcome, for lack of a better word, than we might anticipate given their disability. And again, you've heard me talk a lot about this in neuromotor. What I want to have happen is that the child is who they are, and their illness or their challenge gets folded in with their temperament rather than becomes their identity. And there's a lot of research on how we can counsel and educate families and school team members to optimize who the child is and have them identify with who they are rather than what they're all about in terms of their disease. I never want to hear a child tell me about their disease when I say, tell me about yourself. I want to hear their hobbies. I want to hear their best friend. I want to hear where they went on vacation, whether it's through a computer talking to me or whether it's their language. What I don't want to hear them tell me is a litany of their diseases. I'll get there. I'll ask them about that. But first and foremost, they're mostly normal kids, and we have to honor that and optimize that. There's a lot of research known on how we can do that, and that is a really critical area, I think, for developmental and behavioral peds. Other patients that we see are kids who are having home and school difficulties. I would say probably half of those referrals are from schools or pediatricians and half are from parents themselves. Again, I'm going to take the same history that a pediatrician would take with the luxury of time, the luxury of watching a child walk in my office. My office is at the bottom of a ramp, which turns out to be very helpful. It is filled with toys and a mirror, and yet I've watched hundreds and hundreds of kids over many, many hours play with the same toys. So I get a lot of information from not only the history, but watching the kids explore the toys. It particularly comes up in children with school and home difficulties, because in order to work within my office, they're going to have to talk to me. They're going to have to ask to borrow my toys. I get to watch them explore things, how they interact. Do they look at me? When they look at me, is it communicative or is it not? I get a lot of referrals that say decreased eye contact. Obviously, the issue of autism is foremost on people's minds at that point. And an interesting nuance beside the psychometrics that I get from psychologists is when I get eye contact, is it communicative or not? Or how well do they shift gears? Do they pay attention to their surroundings? Are they clumsy because they're not paying attention to the curved railing, or because they can't keep their body upright, or because I've had kids looking backwards while they're running forward? It just depends. And so what I get to do is meet them in the foyer, go through, literally through the building, and then watch them play and explore for about an hour and a half while I talk to the parents. I often look far more distracted than I am right now because I'm watching the child while I'm talking to the parents. And it's because, unlike a physical exam where I can rely on strength and murmurs and courses of history like fevers and things like that, I'm really looking at how a child explores their world combined with their academic records, family history, and psychometrics. So then where do we go from there? I'm really looking at, I almost always think in terms of domains, and I have the whiteboard behind me because I always end up having to write this down. I never can do it just by talking. But what I'm looking at is motor skills, cognitive skills, I'm not going to be able to fit this, social, and language. Now, obviously, as we look at this, I don't spell well, and I'm hoping all those are correct. I think they are. As we look at this, it's obviously totally false to have them in separate circles. We all know that in order to speak, there should be a social context. There's definitely a cognitive context. If you're too young and your brain hasn't matured enough, you're not going to have the language skills. There's a motor component. Kids who can't motor plan well, so those stage 3 food avoiders and complex food avoidant kids might talk like they have marbles in the mouth, because talking is an act of motor planning. The kids know what they want to say, their muscles are strong enough to do it, but coordinating the muscle activity is what is difficult. So that's why I'm linking that stage 3 food avoidance with how they talk. While they're playing with the toys, luckily for me, they're also talking. So I get to hear the word train a bunch of different times, and sometimes it might be train, and sometimes it might be twain, and sometimes it might be something different. Or the child might pick up one of my trains, and my trains are wood on purpose. They don't have any Thomas the Train or anything like that. And it's because I want to see, does a child recognize an old wooden train as a train? Or do they argue with me that it's not a train because it's not like the train that they're used to playing with? Again, getting at that cognitive function. Can they think out of the box? Can they generalize and think that this is a train even though it looks like no train that they played with before? As I'm looking at the patterns, what I'm really interested in is it a motor issue? So that child who I talked about with dyspraxia or the motor planning issues. Is it a thinking issue where a child might have a genetic syndrome that causes slow development? And so we act according to our cognitive age, and if there's anything that someone's going to walk away with, I think thinking about domains and thinking about the fact that people behave according to their cognitive age are both the key things. And the reason it's key is that, let's say I have a cognitive impairment and I learn at half the pace of normal. So when I am 12, and these are gross generalizations, I understand there's more precise ways to measure this, but humor me for a second. If I'm 12 and I learn at about half the pace of normal, then at 12, I'm going to have the thinking skills of about a 6-year-old. So even though I'm going into 6th grade and people expect me to act like a 6th grader, act your age is something that our culture still says and values. That child is incapable of doing that. Yet being the operative word, because of course we're going to keep working towards that. They will get there. But right now, we can anticipate that their behavioral pattern, their thinking pattern, and even their motor patterns may reflect skills that are more common in a 6-year-old than in a 12-year-old. So the behavioral interventions are going to need to be appropriate to a 6-year-old, not a 12-year-old. Why does it matter? Because Calvin and Hobbes, Calvin is 6.5. Calvin still has a very active fantasy life. Calvin has no clue what is truth and fiction. Calvin is still learning honesty. Calvin is still learning negotiation. Lots of different skills that are appropriate for 6 that aren't as typical at 12. I'm going to want to respond to that child, and more importantly, have their parents understand and respond to that child according to their cognitive age, which is 6. So we're looking at motor, cognitive, social language. Social language obviously are deeply embedded in cognitive. But why are these helpful? Well, if we look at a kid with autism, you're going to see that language and social might be here, but reasoning and motor might be age appropriate. Or you get the kid with a cognitive adaptive disorder. So what used to be called mental retardation is no longer called that, but it's basically an issue where you have delay in all of the developmental domains. So again, I'm going to look back over the history, and you've sent me inches of charts. And what I'm doing is culling through those, saying to myself, what was the trajectory of this child's development? Did they learn at a typical pace until we noticed that their social and their language skills were not evolved as far as their motor skills? Or was it a child who people, about whom people were concerned from the very beginning because they couldn't walk until they were 24 months, and they couldn't, maybe their first word was at 2 years and their first sentence was at 5 years, and they walked at 24 to 30 months instead of 17 at the latest. So what I'm asking myself is, are all of the developmental domains delayed, or are there just a few that are delayed, and if so, why? If we take a child with mild cerebral palsy, everything may be developing completely typically except their motor skills. A child with epilepsy, we should see, depending on the cause of the seizures, normal domain maintenance, except if there's been an alteration in how the parents and teachers have expectations for the child and are setting them too low, because often they feel badly about the seizures or lots of other reasons, in which case we're going to want to get measurements of their potential so we make sure that expectations are matching that. Or it could be a child who, in clinic, we see a lot of kids in neuromotor clinics who might not walk well, but everything else is intact. Probably the classic example is a child who's in college who uses a computer to communicate, I guess, talks like that because he's dysarthric in his speech, but is studying theoretical mathematics. Like, that's the classic cerebral palsy scenario, best outcome, because he has all this technology with which he can communicate and move, and yet his cognitive powers are completely intact. So it just depends on the child. So we've talked about the timing of it. Was it from birth, or was it developmentally acquired later? The key of all milestones delayed versus specific milestones delayed or not developing. Also, did it develop in a typical pattern? We have a little boy in neuromotor clinic that we saw lots of skills delayed, but then we noticed that how he was utilizing language and social skills was really different than how we would typically expect a child to develop. So in that child's case, he had tons of language skills. He can say anything. Many kids can't say. In fact, his language was a little bit precocious, but how he utilized it was to repeat movies he had seen, narrate exactly like the movies he had seen, talk at people rather than with people, share far excessive detail. And obviously what I'm describing is a child who presented with autism. We couldn't tell for a long time because if you're delayed in all domains, you have to get to a certain age where we expect those skills to develop and they're not, or that the social and language skills are discrepant with their cognitive skills. A really interesting differential that I personally loved is looking at either ADHD in the context of multiple medical illnesses or autism in the context of multiple medical illnesses. And the reason is because the nuance of figuring out, is the attention discrepant with their cognitive age? Again, I'm using that concept that one acts according to their mental developmental age, cognitive age, not their chronologic age. In my field, I care about chronologic age because it gives me a ballpark of where they're, quote, supposed to be, end quote, but otherwise I really ignore chronologic age because it's pretty irrelevant to me. I really want to get a thumbnail sketch on where their thinking age is and then meet there. And then with those kids that I find interesting, what I'm looking at is their attention consistent with their reasoning, consistent with their cognitive age or not? Is their social and language development consistent with their cognitive age or not? And that's why often the diagnosis of ADHD and autism are delayed in kids who have complex medical presentations, because they have to develop to a point where we can see a discrepancy in those skills relative to their development. Because they develop slower than others, we have to wait longer, so we can't diagnose them earlier. We have a high index of suspicion. There's a child that you and I both know who we watched for 3 years, highly suspicious he was going to carry the diagnosis of autism. But until he developed to a point where I could see that it was significantly discrepant with his cognitive skills, I did not feel comfortable saying that these two domains, social and language, were discrepant with the other skills at hand. So that's how we tackle those. Let's see what other things. I'm going to think about historically. I'll take another case where I saw a child who presented with grave concerns by his adoptive family. He was adopted at 1.5 years of life. He did very little when I saw him. He couldn't sit. He made no eye contact. He made very few utterances. He had poor muscle tone. And all of us thought, boy, he was not as billed. He was billed as a child from the adoption agency as a child developing fairly normally except for some physical abnormalities. When I met him, he could barely sit up. We had pictures from the adoption agency and we had historical records that told us he was developing normally. Either those are false or the child's grieving. And that child in particular did end up having a learning issue in the long run, but it was really fascinating to see him adjust because he lost all of his skills temporarily. Now again, in a developmental perspective, I'm going to be looking at when he acquires them again, is it like a light switch? He always knew them, but he was overwhelmed and couldn't use them? Or does he really have to relearn them? So that's how we're looking at those things. I think in that case, it was really interesting actually. He developed normally. We happened to have had parents witness him developing normally. He then regressed dramatically at the time of adoption, and 4 months later was back on track and developing normally. That's a child who's going through a psychosocial stressor rather than a child who has a biologic reason. Let's see what else. I think about where abnormalities occur. I have a lot of kids who might have behavioral problems in the school setting but not at home, or vice versa. First off, I'm going to try and get information from both arenas, but secondly, I'm going to try to figure out why that might occur. And people can get really frustrated because it looks like it's the teacher's fault that the child's not behaving in school, or it looks like the family's fault that the child's not behaving at home. As a developmental pediatrician, what I have the luxury of doing with that extra time is sorting through what it is. Let's say a child is doing great in school academically, kind of. Let's put him at 3rd grade, because 5th grade is a different scenario. So let's put him at 3rd grade, doing great academically, but is constantly getting in trouble at places like gym, recess, lunch, art, and at home. I'm going to look at that child really closely for executive function issues. Does he have problems? Usually it is a he. Does he have problems with planning and organization? Does he have problems shifting from one activity to another? Does he have problems with impulse control? If those are the case, then think about it. If you're in a classroom, particularly if you're in a classroom that is run by a very organized teacher, you are not going to have to do much organization because they will have done it for you. Open your math book. Come on, children, now we're going to do this, etc. Playground. No such support. So now they have to know if they can interrupt the child, if they can, that's playing another game. Let's say they want to play Foursquare and they have no impulse control. Then they're going to walk in the middle of Foursquare and it's all going to dissolve to something ugly because the child didn't have the impulse control to not grab the ball and take over. So it's just really different. Now, if you take a hyperactive kid, that child will usually come to my attention early in elementary school because they're busy. They can't sit in their chairs and it disrupts their education. The child without the hyperactivity and just ADD often presents exactly like I just presented. And then academically, usually later in elementary school, the reason I think is that later in elementary school, there's far less visual cues. The teacher isn't as animated usually. Kindergarten teachers are like, hi everyone, let's do, because everybody needs that kind of animation. They have things on their walls and blackboards. They write everything down because not many 5-year-olds and 6-year-olds can follow multiple step requests. But now we get to the cognitive expectation in 5th grade that everybody can get their math book out of their desk, not be distracted by the little erasers and everything else that's there, get their math book out, open to a certain page, and do a certain thing. Many good teachers also provide a visual support, but that is when the child with ADD without the hyperactivity often will start to falter because that's basically a 3-step request. You have to have a good functioning working memory in order to meet that teacher's demand. Or a really friendly neighbor that you can ask what you were supposed to do. Oh, but then what happens? Johnny's speaking out in class, right? So you need to stop disrupting, you need to pay attention, and then the child starts to get frustrated. So that's how I'm looking at those kind of issues. If it's only at school and nothing at home, particularly when I hear a history where summers are great, school vacations are great, I finally get my child back by August and then they're a wreck by November, the school generally has already started looking for learning disabilities, and I'm right with them on that one. That is typically how that is going to present, is a child who is not performing up to academic expectations, and the stressors of participating in school are enough that then their behavior starts to disintegrate. Occasionally, I'll see a child who their behavior disintegrates prior to the school recognizing that there's a learning disability. Typically, it's a very bright child who has a high expectation that they can perform. They know they can perform, and yet they're having trouble and working too hard. And those children often will speak to us behaviorally prior to their academic failure. And getting the schools have been great about getting those educational evaluations so we can understand if their performance is discrepant with their potential. I think that the last thing I would want to talk about is how can you tell the difference between somebody being quirky or having a temperamental difference and when is it worrisome? And basically the way that I look at it, and I think many people who work with kids and behavior look at it, is Quirky is terrific. Quirky is interesting. Quirky is what gives us all color in our world, interacting with children. But when something that is, quote, quirky gets in the way of the child meeting their own goals or meeting their potential, then that becomes problematic. I have no problems with a child who's a wisecracker. I can totally relate to the class clown. But does the child have the impulse control to utilize that humor appropriately, both at time, place, timing, disruptions, realizing when other people think it's funny and when they're not, things like that, when it's getting in the way of their function. If a child is enough of a class clown that they're not able to learn appropriately, that's going to be something that I want to get referred and I want to get a chance to look at. If somebody has a really intense interest in cars and yet can turn off that interest in cars in order to participate in school, in order to talk to his family about other things at dinner, things like that, that's not a child necessarily with autism. That's a child with an intense interest who will probably have a very cool collection of Model Ts as an adult. On the other hand, if the wheels of the toy are more interesting to that child and more engaging than his family, or that he can't play with them and imagine how to play with them, that's a child that all of us would refer for further evaluation. So I think although the diagnosis of autism has become more common and although the diagnosis of ADHD has become more common, we owe it to children and we owe it to ourselves to distinguish between when something is an impairment of function, an impairment of the ability to participate up to your potential, thus disabling, and when it is simply a temperamental variant that we all need to work around and we need to provide lots of education and support and encouragement, but bottom line is it's who they are and it's not getting in their way. And so at that point, I'm going to send them back to primary care and counseling and all those other good things, and that's how I would fold into that scenario. So Sue asked me to talk about tricks of the trade and when to worry. First of all, I think passing a case by someone who spends their days watching children explore the world, if you're worried enough as a pediatrician or a school nurse to wonder, then passing it by us is not a problem. I would welcome those questions. I think it's far better to let me hear the case, just like we do if we're worried about a septic newborn. We call the neonatal intensive care unit and say, this is what I'm seeing. Sometimes it's very straightforward and we transfer them immediately. We don't even call to pass it by them. But other times you've got that, that 6-month-old who's now been sick 5 times and they're sicker than the other children that you've seen. And now you're beginning to wonder if they have a metabolic disorder. Are they getting sick out of proportion with their illness? So that caveat that all of us learn about metabolic kids is, does this child get sick out of proportion with the illness that they have? So in other words, a child who gets the stomach flu who ends up needing IV hydration or a hospital stay every time, that's a child who's a flag to us that they need more evaluation. Developmentally, what are those flags? This is a cool question. So let's go with autism first. Obviously, everybody knows decreased eye contact. Everybody knows decreased speech. So the MCHAT evaluations are fabulous. If a child has a positive MCHAT, I find most people are referring. I think it's important to remember that some of the tools like the ADOS were set up as screening tools. They have they have some problems with sensitivity and specificity in terms of ADHD, anxiety, and other psychological issues, so that they look like autism and they're not necessarily. So just keep in mind that positive result isn't always the same thing. If you get back an evaluation from early intervention services and it says that the child has autism, but there's things about it that don't fit with your experience, that's a child you should refer because that's a complex child. The predictability of those screening tools in the context of developmental differences is actually not nearly as precise as I think people perceive it to be, and there's some very nice research to show that that's the case. So that's one caveat. I think another flag is if a child has a medical disorder and then has alterations in thinking skills, language skills, social skills, that's a child I want to see, because in general pediatrics I did not have a working knowledge, and maybe other people do, I did not have a working knowledge of the learning disabilities associated with very specific medical disorders. And I wasn't expected to know that. But does a general pediatrician know the learning pattern of a child with hydrocephalus and what type of learning disability they're at risk for versus not. And that, I think, once you get into any child who has a significant medical illness, who is then developing atypically, I would like to have a chance to see that child or have someone else take a look at that child. I think it's fairly straightforward to attribute it to the medical disorder that's happening, and understandably, if the child is having a lot of medical issues, it impacts development. But we have an opportunity as developmental behavioral pediatricians to educate the school team and the family about how to accommodate their education to that medical experience, and also how to anticipate the learning issues associated with many given medical issues. So that's, I think, probably a referral base that I don't see referred as often as I think it might be helpful to see them, if that makes sense. Other flags are going to be the child who previously has done well and is beginning to get discouraged and depressed, particularly in later elementary school and middle school. The demands for executive function, planning, staying on task, starting a task, organizing, all of those things that you need to do in order to succeed become amplified in later elementary school to middle school. So at the very time a child, quote, develops an attitude as a pre-adolescent, and people sometimes attribute the struggles to that, I just would hesitate. It's unusual for a child who has been, quote, compliant or been very successful, been outgoing, been successful in both social and school arenas to suddenly change. So I'm going to want to really look at that child, and I would like to see that referral to see, is there anything else going on behind the scenes that's leading down that pathway, rather than assuming that it's hormones and attitude. Sometimes it is hormones and attitude, don't get me wrong, but usually it's hormones and attitude over the baseline temperament. If a child suddenly has a change in that temperamental attitude, that would be unusual to me, and they're either going to end up in psychiatry or behavioral medicine or psychology, and that's where they need to be. Referring beyond that, I would say genetic syndromes. Any child who is perceived as having been medically threatened by their parents is at risk to be raised differently than they would if that experience hadn't taken place. So fragile child syndrome is what it used to be called, and that's a real entity. And what's interesting is, even if the physician knows the child wasn't actually significantly threatened, let's say a child was born and they were floppy and blue, and we, quote, just had to bag them with oxygen. If the parent perceived that the child wasn't breathing on their own and that the child almost died, and you hear a parent say that, well, they almost died in the newborn period, and I know they're fine now, but they almost died, that's a flag that that parent is having difficulty putting that in its place and understanding it appropriately, and then parenting this child normally. Why does that matter? Because it affects the child's outcome both in adolescence and in adulthood, and we want a chance to alter that course, and it clearly can be altered both with educational and cognitive behavioral therapy. So that's another flag that I would be thinking about. I think the last area of referral for me would be, even when the pediatrician or family practitioner is not worried because they know the child is fine, they've explained it to the best of their abilities why they feel the child is fine, and the parent is still convinced something is wrong. That's still a good enough basis for a referral, although I would like to know why you think the child's fine, and I really want the inside scoop because the child probably is fine. But if the parent doesn't feel heard, in my experience, they can't let that concern go. Therefore, they will be hypervigilant about that child and alter how they interact with that child. Why does it matter? Because it alters their expectations, it alters their responses, and therefore alters a child's self-image and outcome. It's a straightforward thing that it's exactly the same as if you're not worried about growth failure or something else, and you get out that growth chart and you explain to the parent why they don't need to be worried because the child is now fine and they're growing at the 50th percentile. The exact same is true for development of medical illness. Even though you're comfortable, if the parent still isn't, utilize us. Consult. It'll be a fast consult. We'll see them a couple times until the parent's comfortable that the kid really is fine, and then they move on, or we'll refer them for further testing to make sure that the child's fine or that we're not missing anything. But I don't think it's any different than it is with medical issues. If we can't allay the parent's concerns or your own concerns, you should refer out because there's a good reason that that concern is there. So I hope to be a source for consultation, either email, by phone, or in person, to really try and smooth that path between kids who either have genetic disorders, medical disorders, or developmental differences, solely so they can optimize function. And then I think disability has a whole lot less impact than it would otherwise.